Hi everyone, our subject today is neck pain in pediatrics. Basics. Most causes of neck pain and stiffness in children are benign, however potentially life-threatening condition, meningitis, cervical spine fracture must always be considered in the evaluation. History and physical examination. The history should clarify the onset, duration, and nature of the complaint and include a comprehensive review of system. Fever, high index of suspicion for meningitis in the setting of headache, altered mental status, seizure, photophobia, rash, or CNS abnormality. Without obvious source of infection, consider occult infections such as vertebral osteomyelitis, discitis, or spinal epidural abscess. Assess for symptoms of neurologic injury, headache, vision changes, ataxia, gait disturbance, paresthesia, sensory changes, and bowel or bladder dysfunction. Trauma mechanism to indicate severity. In young children, trauma may be unwitnessed. Other symptoms to discern etiology: throat pain, pharyngitis, retropharyngeal abscess, peritonsillar abscess, epiglottitis, ear pain, otitis media, otitis externa, mastoiditis, dental pain, abscess, loading angina, painful neck swelling, cervical lymphadenitis, branchial cleft cyst abscess, thyroglossal duct cyst, respiratory symptom, upper lobe pneumonia, neoplasm, medication, dystonic reaction, ENT or dental procedure, Grissel syndrome. The physical examination should note stiffness and range of motion of the neck and the specific nature and location of the pain. Neurologic, perform a complete neurological exam focusing on sign of spinal cord involvement such as motor and sensory function, gait, deep tender reflexes, and rectal tone. Spasm and tenderness ipsilateral to the head rotation, chin points to pain, suggest rotatory subluxation as the sternocleidomastoid muscle attempts to reduce the deformity. Spasm and tenderness contralateral to head rotation, chin points away from pain, suggest inflammatory or congenital muscular torticollis as the affected sternocleidomastoid muscle is pathologically shortened. Torticollis or wry neck describe a condition in which the infant's or child neck is tilted to one side and rotated to the opposite side. It is the primary manifestation of congenital torticollis, but it can also be symptoms of several other problems: infection, CNS neoplasm, structural abnormality, neurological disorder. A thorough neurological examination include mental status, cranial nerve involvement, upper extremity pain or weakness, and cerebellar function is important. Chest exam may reveal a decreased breath sound, crackles, egophony, or dullness to percussion, indicating upper lobe pneumonia, rarely associated with meningism. How to approach the child with a stiff or painful neck after performing history and physical examination. It is congenital. If it is yes, differential diagnosis: congenital muscular torticollis, congenital hemivertebra, Klippel-Feil syndrome, Sprengel deformity, and other congenital syndrome. If it is not congenital, is there history of recent trauma with any of the following: midline cervical spine pain, pain with neck movement, focal neurological sign, or loss of conscious? If it is yes, stabilize the cervical spine, perform X-ray. If it is normal X-ray, this is soft tissue injury, contusion, sprain, strain, spasm, sternocleidomastoid muscle hematoma, or spinal cord injury without radiographic abnormality. If it is abnormal, differential diagnosis: cervical fracture, cervical dislocation, and cervical subluxation. If there is the patient has no history of trauma or has none of the following, if the patient has fever, acutely ill, if it is yes, look for meningeal sign. If it is present, if it is yes, perform lumbar puncture. If it is abnormal, differential diagnosis, meningitis, encephalitis, subarachnoid or epidural hemorrhage, and epidural abscess. If it is a normal lumbar puncture result or the patient does not have meningeal sign, differential diagnosis, lymphadenitis, pharyngitis, retropharyngeal abscess, viral myositis, vertebral osteomyelitis, discitis, mastoiditis, juvenile idiopathic arthritis, neck muscle abscess, upper lobe pneumonia, thyroiditis, jugular thrombophlebitis, intervertebral disc calcification. If the patient not ill does not have a fever, is there a neurological sign or symptom present? If it is yes, perform neuroimaging. Differential diagnosis, tumor, atlantoaxial instability or subluxation, Down syndrome, Grissel syndrome, other etiology, spinal cord injury without radiographic abnormality, ocular torticollis, CNS hemorrhage or other space-occupying lesion, dystonic reaction, skeletal anomaly, occiput atlas axis, vestibular disturbance, and cervical radiculopathy. If the patient not acutely ill and does not have abnormal neurological sign and symptom, consider imaging. Differential diagnosis, benign paroxysmal torticollis, non-traumatic atlantoaxial instability or subluxation, osteoid osteoma of the cervical spine, juvenile idiopathic arthritis and other collagen vascular disease, Sandifer syndrome, thyroiditis, intervertebral disc calcification, spontaneous pneumomediastinum or psychogenic. Red flag. In infant, early presentation of meningitis can be subtle and non-specific, often with the irritability without fever, bulging, fontanelle, or sign of meningeal irritation are late sign of meningitis. In older children, the classic sign of meningitis, fever, headache, vomiting, neck stiffness, may not occur. Rather, they may present with the virus-like illness and mixture of leg pain, drowsiness, confusion, neck pain, seizure, and behavioral changes. Within a few hours, it rapidly progressed to septic shock, hypotension, disseminated intravascular coagulation, and death. Vigilance and a high degree of suspicion are required. Skin of child with the meningism should be carefully searched for any rash or petechia of the meningococcal disease. Even if pneumonia is diagnosed, a child with meningism requires lumbar puncture to exclude meningitis. Drug history is essential to confirm a rare cases of dystonic drug reaction, oculogyric crisis. Although acquired torticollis is mostly due to minor cervical muscle trauma or an upper respiratory tract infection, careful evaluation is essential to exclude serious conditions such as brain tumor or vertebral infection. Mild neck stiffness following sleep may result from sleeping in an awkward position. Gentle active rotation and flexion are usually achievable. Congenital muscular torticollis appear in the first several weeks of life. The head is tilted toward the shortened sternocleidomastoid muscle. A fibrotic mass is frequently palpable in the muscle belly. Other signs of intrauterine mechanical deformation, plagocephaly, facial asymmetry, foot deformity, developmental hip dysplasia are frequently present. Plain X-ray of the cervical spine to rule out congenital vertebral abnormalities should be obtained in the absence of any of these associated clinical findings or if there is no response to the stretching program. A suspected cervical spine injury should be treated in acute setting with the cervical spine immobilization until appropriate X-ray can be taken. The most common cervical spine subluxation involvement, the atlantoaxial C1-C2 joint. It may result from mild as well as severe trauma. Symptoms can include neck pain, sternocleidomastoid muscle tenderness, and torticollis. Symptoms of spinal cord compression are rare in children. Although clavicular fracture are usually indicated by localized pain and tenderness, the predominant presenting symptom can occasionally be torticollis due to spasm of the sternocleidomastoid muscle. The ligamentous laxity and hypermobility of the cervical spine and potentially narrow spinal canal in young children place them at risk for spinal cord injury without radiographic abnormality. These injuries are due to stretching or distortion of the spinal cord or nerve root. Careful history taking is essential because initial neurologic deficit, weakness, paresthesia may be transient, resolving shortly after the injury, then recurring minutes to days later. MRI is indicated when suspected. In meningitis, meningeal sign, knuckle rigidity, Kernig and Prudzinski sign are usually accompanied by systemic sign of illness, including fever, altered consciousness, poor feeding, headache, and possibly seizure. Classic meningeal signs are not always present in meningitis, particularly in children younger than 18 to 24 months. With bacterial meningitis, CSF analysis usually reveal a low glucose level of usually less than 40 mg per deciliter, a high protein level, a neutrophilic leukocytosis, and positive gram stain. Any child with meningism should be considered as case of meningitis until it is proved otherwise. In any patient with the stiff neck, it is important to assess the immunization status of the child. Tumor of any origin, nerve, muscle, bone, may present acutely with the stiff neck owing to swelling or nerve compression. Nocturnal pain may indicate an osteoid osteoma. Diagnosis is by X-ray or MRI. Hypermobility or instability. Hypermobility or instability of the occipito-atlantal or the atlantoaxial joint due to ligamentous hyperlaxity occur in up to 60% of children with Down syndrome. These children are at increased risk for spinal cord injury. Patient may be asymptomatic or have slowly progressive neurologic symptoms including neck pain, clumsiness or increased falling, change in tone, weakness, sensory deficit, or change in bowel or bladder control. The Special Olympic currently requires cervical spine imaging for patients with Down syndrome prior to participating in certain activity that may carry an increased risk of spinal injury. Otherwise, routine cervical spine imaging for asymptomatic patient with Down syndrome is currently not recommended as a routine part of health maintenance by the American Academy of Pediatrics. Families, however, need to be continually educated regarding worrisome signs and symptoms that are suggestive of spinal cord impingement and would warrant urgent evaluation. Grissel syndrome is a rare mild atlantoaxial subluxation that occurs in children without other risk factor for subluxation. Down syndrome, connective tissue disorder, rheumatoid arthritis, and in the absence of trauma. It is presumed to be due to inflammation related to the pharyngitis or upper respiratory tract, causing increased laxity of the cervical spine ligaments. Other etiology include a rare congenital condition, Marfan syndrome, Klippel-Feil syndrome, os odontoium morquio syndrome. A child with the Klippel-Feil malformation, short neck, fusion of the cervical vertebra, has a high rate of renal malformation, about 40%. Eye problem, nystagmus, superior oblique muscle weakness, strabismus, may result in compensatory neck stiffness and torticollis in infant. Neuroimaging may not be indicated if a drug effect is suspected. Several antipsychotic and antiemetic medication, most commonly haloperidol, prochlorpromazine, and metoclopramide, can produce acute dystonic reaction within days of exposure. Oculogyric crisis is dystonic reaction characterized by torticollis and involuntary deviation and fixation of the gaze, usually upward. Benign paroxysmal torticollis is characterized by torticollis of the variable duration that may or may not be accompanied by symptoms of pallor, agitation, ataxia, or vomiting. The onset is in the first year of life and consciousness is not impaired. The family history is usually positive for migraine. Thank you for your listening.